is July 20th, and welcome to Head and Neck Live. We have a very dynamic special team of speakers this morning. We have Dr. Nyall London as well as Diana, who will be speaking to us about their research on skull-based tumors. So just a brief introduction to Dr. London. So he's currently an associate professor at Johns Hopkins in the Department of Otolaryngology, Head and Neck Surgery. He actually, we were just talking, he was actually a junior resident of mine. And so obviously we've known each other for a long time. And we've always been very impressed with his ability to balance clinical work as well as research. And obviously, you know, he currently is running a very successful research lab at NIH. And his focus is on disorders and cancers involving the nasal cavity, sinonasal, and the skull base. So he, after doing the otolaryngology residency, he completed his fellowship at Ohio State University under the direction of Dr. Corral. And Dr. London was the research mentor for our second speaker, who many of us very well know her. So her name is Diana Lopez. She's currently a fifth year medical student here at the Cleveland Clinic, Lerner College of Medicine. And so she spent a year in Bethesda under the mentorship of Dr. London. So she's currently applying to residency in otolaryngology and is a sub-I with us. And she's done an amazing job. And she's obviously a rising star and a future leader in our field. You know, it's recognized through all her work through medical school, as well as a recent scholarship that she was awarded. For her leadership potential, humanistic dedication, and passion for research and clinical excellence. So congratulations. So this morning, their talk will be titled Mechanisms to Enhance Combinatorial Immunotherapeutic Approaches for Sinonasal and Skull-Based Tumors. So thank you both so much.
Great, thank you so much. Thanks everyone, you know, for the invitation. We're both excited to be here and be able to share the work that we've been doing recently. It was great to have Diana in my lab for the last year. So thanks so much to, you know, for sending her over to the NIH. And she did a fantastic job and worked very hard and got a lot done in a year's time. So I thought it'd be great to have her, you know, kind of share the work that she'd done over the past year. And so, you know, she'll start off first by sharing that work. And, you know, I think it's better to have her share it than me share it because she's the one that did it. So it'll be good to have her share that work. And I just want to add that, you know, even though we'll be talking about sinonasal and skull-based tumors today, that a lot of the, you know, malignancies hit all of our otolaryngology subspecialties, and a lot of the principles that we're discussing today are potentially applicable to many of the other fields or subspecialties within otolaryngology. So with that, I'll turn over to Diana, and after she's done, I'll talk a little bit about translating some of her findings and some of the clinical trial approaches that we're working on at the NIH. Whoops, sorry, let me unshare my.
Okay. I'm just sharing my screen. Let me know if you can see the slides, okay? Okay, thank you. Thank you so much, Dr. London and everybody here, Dr. Koo and everyone at the Head and Neck Institute at Cleveland Clinic. I'm really grateful for the opportunity to present my work that I did at the NIH. I'm very proud of the work we were able to put together this past year in making headway for immunotherapeutic approaches for sinonasal and skull-based tumors. I'll be focusing mostly on the work I did in Chordoma, but I'll also briefly touch upon our plans for future studies in esthesioneuroblastoma using these same techniques. Okay, I have nothing to disclose. This is the MRSP Medical Research Scholars Program Fellowship Disclosure Statement. And so to talk a little bit about chordoma. Chordoma is a rare, invasive, and devastating bone malignancy. Since it's a notochord remnant tumor, it can arise anywhere along the axial notochord, including the clivus, the sacrum, and the spine. We're most interested in the skull-based tumors that arise at the clivus or at the craniocervical junction, as those are the ones that as sinonasal and skull-based surgeons we can approach. This is an MRI image of a clival chordoma found just anterior to the brainstem. And with chordoma, the prognosis is fairly low, with 5 and 10-year survival rates of 70 and 40% respectively. But the reason that they're so difficult to treat is because they're known to be resistant to chemotherapy and to radiation. Recurrence is also prevalent. So metastasis for these occur in 40% of cases, and after metastases occur, survival is pretty dismal at about a median of 12 months. So in order to make more advancements in chordoma therapy, specifically with targeted approaches such as immunotherapy, we need to better understand the tumor microenvironment of these chordomas. So far, it's been preliminarily described as known to be complex, but through the study, we can hopefully identify some new targets to go after. And so we went about doing this using a technique called multispectral immunofluorescence. Before I do that, I'm going to talk a little bit about what the tumor immune microenvironment is. And this is an amalgamation of tumor cells, immune cells, vascular cells, and fibroblast cells that surround the tumor. It also dictates what the host immune anti-tumor response will look like. Of particular interest within this tumor immune microenvironment are 3 cell compartments. Those are myeloid cells, T cells, and NK cells. Myeloid cells include things like macrophages, monocytes, neutrophils, or PMNs, and these have immunomodulatory effects on the tumor immune microenvironment. Importantly, they can also differentiate into myeloid-derived suppressor cells, which have an immunosuppressive effect on T cells and NK cells. T cells in particular are the workhorse of the anti-tumor response. They enact immune surveillance, they recognize and destroy tumor cells. However, within that T cell category, I want to specifically highlight T regulatory cells, which are known to keep the immune system in balance, and they actually work in an opposite way as cytotoxic effector cells in that they promote an anti-tumor immune response. And then lastly, NK cells enact tumor cell destruction as well. However, they do so independently of antigen presentation, and they work in concert with antibodies and T cells to attack this tumor. Immune checkpoint blockade is something that's garnered a lot of recent interest. There's a lot of really great studies going on with immune checkpoint blockade, and the idea behind this is the harnessing a patient's immune system to maximize the therapeutic efficacy we can obtain and also limit treatment toxicity that's inherent to things like radiotherapy or chemotherapy. It may provide benefit in chordoma, specifically via the PD-1, PD-L1 axis or the programmed death protein, programmed death ligand axis, as this is a known pathway exploited by cells, by neoplasms, including chordoma, to evade immune system response. In fact, there's a clinical trial underway currently for nivolumab, which is a PD-1 antibody. And so we've used multispectral immunofluorescence, which is a technique that allows for advanced staining of human tissue specimens with multiple antibody marker panels at once. So when we build these panels, we can then quantify the nature of the immune cells that exist in the tumor microenvironment. There's a picture shown to the right here of a stained chordoma. We can quantify the spatial arrangements between myeloid cells, T cells, NK cells, and the tumor's target cells themselves. And we can look at co-localization with immune checkpoint markers such as PD-1 and tumor-infiltrating lymphocytes. It's a very powerful technique that really hasn't been used to its full potential in chordoma until we did it. But it has been previously employed in the study of head and neck squamous cell carcinoma and looking at that tumor microenvironment. And importantly, those studies have found that high lymphocytic T cell infiltration of head and neck squamous cell carcinomas by T cells carry a favorable prognostic response to induction chemotherapy. And so we have hypothesized that myeloid cells, T cells, and NK cells would be identifiable within the chordoma tumor immune microenvironment, and thus we have targets for immune checkpoint blockade and immunotherapy. And we also thought that effector cells, so cytotoxic T cells, for example, may have restricted ability to penetrate the chordoma tumor, while immunosuppressive cells, such as myeloid cells, may exhibit closer proximity to the tumor cells. And our goal was to guide rational design of immunotherapeutic strategies for chordoma for future clinical trial design. So our study design, big picture, is basically we obtained 57 chordoma slides, human tissue slides, and we applied this multispectral immunofluorescent staining. Here you can see a whole slide acquisition. We stained them using an automatic system, the Leica BondRx system, and we scanned them using Vectra Polaris, which allows us to obtain very high resolution images. I then annotated the tumors digitally based on cytokeratin. Cytokeratin is a marker that allowed us to distinguish chordoma cells from non-chordoma cells, as chordomas stain with cytokeratin, and you'll see those images in white, the cytokeratin in white in our images. And then I analyzed the cellular spatial analysis with a Halo software, which allows us to see how many types of immune cells there are, where they are in relation to the tumor cells. And I use GraphPad to then correlate these findings with clinical findings of our patients. And this is an example of how I would annotate tumor versus stroma in a chordoma. So all of the white area is cytokeratin positive. That's chordoma. Everything else is stroma. And so on the right side, you can see after I digitally annotated the chordoma tumor parenchyma is shown in red and the stroma is shown in green. So we designed 3 panels to look at the 3 immune cell compartments we were interested in. The first was a myeloid cell panel that included CD11b, CD14, 15, HLA-DR, CD68, and cytokeratin. And this allowed us to look at pan-macrophages, monocytes, and polymorphonuclear cells, or neutrophils. Then we designed a T-cell panel looking at CD4, CD8, FOXP3, Ki67, which is a proliferation marker, PD1, important to our immune checkpoint blockade we had spoken about before, and cytokeratin. And this allows us to look at CD4 positive T helper cells, CD8 positive cytotoxic T cells, T regulatory cells, and then the PD1 positive cells as well as the proliferating cells. And finally, we designed an NK panel that included CD16, CD56, CD3, and granzyme B, allowing us to look at NK and at granzyme B. Granzyme B kind of told us whether NK cells were in their active state or not. And so in terms of sample size, we obtained 10 slides from the Chordoma Foundation, 10 slides from Johns Hopkins, and 1 tumor microarray from the NIH Department of Pathology that included 37 chordoma tumors, totaling 57 chordomas, which is a fairly large sample size for such a rare tumor. And so delving into my results here, I want to first talk about the myeloid cell panel and the quantification analysis. On the largest inset on the left, you can see all of the colors turned on at once for the myeloid panel. And on the right, you can see them divided by marker. And so different combinations of these phenotypes would allow me to look at pan-macrophages shown on the bottom left graph, monocytes in the middle, and neutrophils on the right. And so what we see is that pan-macrophages make up the majority of the myeloid cell population in chordoma. And additionally, and importantly, there's a significantly greater amount of tumor parenchyma infiltration by pan-macrophages when compared to those found in the stroma. And so as we spoke about, myeloid cells can differentiate into myeloid-derived suppressor cells. These exert an immunosuppressive response. And so the fact that we found these to be more likely to infiltrate tumor parenchyma rather than staying out in the stroma suggests that these myeloid cells may be exhibiting an immunosuppressive response within the chordoma tumor immune microenvironment. Here is the T-cell panel. I just wanted to give a visual of what it looks like when it's fully stained on the left, and then by marker, divided by marker on the right. You can see here just visually that T cells tend to stay out into the stroma in that middle space that's not cytokeratin positive, it's not white, so therefore it tells us it's not stroma. So these T cells really have a harder time infiltrating the tumor parenchyma than those myeloid cells do. And then the quantification analysis kind of demonstrates that same finding, that CD4 positive T helper cells, CD8 positive cytotoxic T cells, and T regulatory cells are all found at significantly greater rates in the stroma versus in the tumor. So they're not infiltrating as effectively as we would like. Notably, CD positive 8 cells, so the effector cells, the proliferating types and the PD1 positive types were all found to be significantly more present in the stroma versus in the tumor. And only about 20% of T cells overall were found to be proliferating in our samples. But there were a huge proportion of PD-1 positive T cells, which kind of substantiates the argument of going after PD-1 inhibition with something like nivolumab, about which a clinical trial is running right now. And then we wanted to take this one step further and look and actually characterize the tumor parenchymal inclusion versus exclusion of our T cells. So we came up with a definition that said that a tumor to stroma infiltrate ratio of greater than 1.5, shown in blue on the left of the graph, delineates substantial tumor parenchyma infiltration versus stroma to tumor infiltrate ratio of greater than 4.5 kind of substantiate or delineates greater stromal invasion. And so as you can see here, T cells overall seem to take on a behavior of parenchymal exclusion. So they don't tend to infiltrate the tumor as well as we would like in our 57 chordoma samples. And then just to provide some visuals, on the bottom left picture, you can see one of the examples of a tumor that is highly infiltrated by T cells within its parenchyma. And then on the right, you can see the opposite case, a tumor that it has not been effectively infiltrated into that white parenchymal space. All of the T cells kind of stay out in the stroma. And now to talk about the last compartment, the NK cell compartment, we found that NK cells are sparsely identified within the chordoma tumor environment. And moreover, these seem to be granzyme B negative, so in a non-active state. And that tells us that there is more work to be done in terms of NK cells. We can actually upregulate them. We can increase their activity, increase the proliferation, whether it's by adoptive transfer, which we have another student last year who did a lot of these in vitro experiments on chordoma and found that if you introduce NK cells, the chordoma cells effectively lyse or die. Or we can use things like an IL-15 superagonist to increase the activity of the NK cells and increase the efficacy of their killing of the chordoma tumor cells. And here I did a more more sophisticated immune cell spatial analysis. On the left, you can see a chordoma sample, the full tumor, stained for CD8 positive T cells, CD4 positive T cells, tumor cells, and Tregs. You can see I've zoomed into an area of high T cell infiltrate, and then on the right-hand side, you can see a real-time spatial analysis in which all of the CD4 T helper cells are shown in green here. They're in the stroma. The tumor parenchyma is surrounding it in white, and that is how I measure the distance between each CD4 positive T cell and the chordoma tumor cells. And once I did this analysis on all of our 57 tumors, you can see the proximity line series of CD4 positive T helper cells to tumor cells on the left, CD8 positive T helper cells to tumor cells in the middle, and Treg distance to tumor cells on the right. And overall, what we're seeing in part D here is that myeloid cells, pan-macrophages, monocytes, and PMNs are all found to be closer in proximity to tumor cells than T cells shown in the bottom in blue. And again, this tells us that these myeloid cells are likely exhibiting an immunosuppressive response on the tumor microenvironment and are thus preventing the CD4, CD8 positive T cells from actually infiltrating the space with the chordoma tumor cells. We also wanted to look at the relationship between T regulatory cells and CD8 positive T effector cells. This is because Tregs are known to abrogate the response of CD8 positive effector cells. They also limit the growth of these effector cells. And so we wanted to know if Treg distance to CD8 T cell would be something we can go after in terms of immunotherapy. Can we limit the Treg response and thus upregulate the efficacy of CD8 T cell killing? And we found that the percent of Tregs within a 20 micrometer distance of CD8 positive T cells is actually closer to the non-proliferating CD8 T cells than to the proliferating. So this implies that when you have a Treg that's closer to a CD8 positive T cell, it may be limiting its ability to proliferate, grow, and exert its effects on the tumor cells. Now moving on to our clinical correlation work, so we looked at the patient demographics and the clinical data. And of the 57 tumors that we were able to obtain, we had clinical data for 20 of them, the ones that came from Chordoma Foundation and from Johns Hopkins. Of these, our mean patient age was 49. 40% of our cohort was of female sex, 94% was Caucasian, and 15% was of Hispanic ethnicity. The majority of the tumors we looked at were skull-based tumors and sacral tumors, as you can see on the bottom left. And then disease stage, the majority of our tumors were either primary or advanced disease stage. We only had 2 recurrent tumors and no metastatic tumors to look at, but that's a future study we'd like to do. We'd like to get our hands on some recurrent tumors and metastatic tumors to see if there's any difference in the tumor immune microenvironment. Most tumors were gross total or near gross total resection, and 55% of them received radiation, none received chemotherapy. When we looked at this immune cell density, so that quantification of myeloid cells, T cells, and NK cells by anatomic site, we see that there's really no difference in tumors that originate from either skull base, spine, or sacrum or coccygeal region. And so this is actually reassuring because it tells us that we can use similar therapeutic approaches for chordomas despite their anatomic site of origin, and that we can enroll these patients in clinical trials kind of uniformly despite whether the tumors came from the skull base or otherwise. And there's a similar take-home message here when we looked at immune cell density by disease stage. You can see the myeloid compartment up top, the T cell compartment in the middle, and the NK compartment on the bottom all show that there's no difference between the tumor immune microenvironment, immune cell infiltration between primary and advanced disease stage tumors. Now I'm going to transition a little bit into esthesioneuroblastoma, also known as olfactory neuroblastoma. It's a rare malignancy of the anterior skull base. It originates from olfactory neuroepithelium in the upper nasal cavity near the cribriform plate. You can see a visual of that here on the right-hand side. And it has an insidious progression. Although it has relatively favorable 5-year survival rate of 80%, and it's treated with surgical resection and adjuvant radiation, the challenges to successful treatment of these EMB or OMB tumors is really local regional recurrence. And so what we would like to do is investigate the immunotherapeutic role in this type of tumor in the same way that we did chordomas. So there is also a poor grasp of the ONB's tumor microenvironment. We know that it's a heterogeneous microenvironment. It's only really been looked at with immunohistochemical studies. And so what we've done is gone ahead and stained a series of esthesioneuroblastoma tumors with that myeloid cell panel I had shown previously. It's seen here on the left, and the T cell panel on the right. We've also stained them with an NK panel, and our lab will be working on the analysis of these over the course of the next year to see if there's some nuance we can learn about the tumor immune microenvironment in esthesioneuroblastoma to guide future clinical trials as we've done with chordoma. And of our patient characteristics for the 47 tumors we have so far, 60% are of male sex. The majority are primary tumors at 85%. Only 15 are recurrent, and 34% are of high IMS grade. So our conclusions, specifically with the work that we've done characterizing the chordoma tumor immune microenvironment, we've learned that we can identify myeloid T cell and NK cell compartments or composition within the chordoma tumor immune microenvironment. That's important because it tells us that these cells exist within that microenvironment and that we can target them with immunotherapy. We've made successful comparisons between tumoral and stromal infiltration of these immune cell compartments. We've obtained a greater understanding of the spatial relationships between these immune cells and the target tumor cells. And overall, what we found is that there's an increased proximity of myeloid cells to tumor cells, along with a decreased tumor penetrance by effector T cells. There's also co-localization of T regulatory cells and cytotoxic T cells in the stroma. And so when we compare this to studies that have been done in head and neck squamous cell carcinoma, for example, there's been strategies to use restriction of trafficking and function of immunosuppressive myeloid cells. Specifically, there's a gene called CSF2, colony stimulating factor 2, which is linked to MDSCs, or myeloid-derived suppressor cells, and it's been strongly associated with poor overall survival in patients treated with PD-1 therapy. Additionally, there's a CD34 marker, another marker for MDSCs that has been looked at in head and neck squamous cell carcinoma, and it's found to be increased in tumors that don't respond to immunotherapy. And so this tells us that this work, which has been first done in head and neck squamous cell carcinoma and other tumor types, shows that if you actually go after the immunosuppressive behavior of the myeloid cells, we may get a better response to T cell modulation or immune checkpoint blockade via T cell. And we also see that by anatomic site and by disease stage, there are no notable differences in myeloid cell, T cell, and NK cell infiltration of our chordomas, which, as I mentioned, lets us know that we can treat all of these chordomas similarly, just based on their tumor immune microenvironment. And furthermore, that we shouldn't avoid including all of these tumors, all of these chordomas in our future clinical trials. And the significance of this work is that future treatment strategies for chordoma should be aimed at restricting trafficking and function of potentially immunosuppressive myeloid cells and potentially immunosuppressive Tregs. This will allow for enhancement of T cell and NK cell killing. And this restriction of immunosuppressive myeloid cells can also be combined with immune checkpoint blockade that specifically targets T cells. It can be combined with IL-15 superagonists that increase the efficacy and activity of NK cell killing, all with the goal to allow for greater effector T cell penetration and killing of chordoma cells. And additionally, one other success of this project was the establishment of multispectral immunofluorescence protocols in chordoma. This is a powerful tool that will now allow us to look at pre versus post-therapeutic tumor microenvironments when we set up our upcoming immunotherapy clinical trials. And so I'd like to acknowledge first and foremost Dr. London, my PI for the past year during my research fellowship, who did an amazing job in mentoring me, guided me through this project and others, and really taught me how much I enjoy this kind of research, this kind of intellectual inquiry. And I hope that we keep this mentor-mentee relationship going for many years to come. I'd also like to thank Yvette for technical assistance in teaching me how to stain all of these tumors, as well as how to analyze them. All of our lab members, Dr. Allen and Benoit, as well as all of the head and neck surgery branch, and our collaborators in the Hodge Lab. I'd like to thank my fellowship program, the Medical Research Scholars Program at NIH, as well as the NIDCD for the opportunity to do the research, and the Cleveland Clinic Lerner College of Medicine for giving me the training and the tools I needed to set me up to become a successful physician scientist in the future. And lastly, I'd like to thank the Cleveland Clinic Head and Neck Institute for allowing me the amazing opportunity to give this talk and share this work with you.
Thanks, Diana. As everyone can see, Diana did a tremendous job and accomplished a lot over the last year. So let me go ahead and share my slides.
You gonna do
Okay.
questions at Jamie?
Yeah, let's let me touch on a couple of points that Diana talked about, and then yeah, if we can hold questions till the very end, I'll make sure and leave some time for questions.
Sounds great. Thank you.
So my one disclosure, thanks again everyone for the invitation to speak. It's been great to see many old friends and to share our work with you today. The only disclosure I have is unrelated to our talk today, is research funding from Merck to study HPV-related or associated sinonasal malignancies. So for those who may be unfamiliar with the MRSP program, this is a competitive one-year research program for medical students at the NIH. And this right here over on the right is a picture of the NIH. my slide is not, oh, there we go. So this is building 10 right here. This is the 200-bed inpatient research hospital at the NIH, and this is our lab is connected within building 10 to the research hospital, and this is where the lab is located in Bethesda, Maryland. And the MRSP students typically live in this building. It's just off the photo on campus at the NIH, and so they're with easy walking distance to the hospital and the research lab. So from what Diana shared with you this morning, comprehensive characterization of the chordoma tumor immune microenvironment suggests that if we try to move forward with a rational combinatorial immunotherapy approach, that we should use two main aspects. And the first one is decreasing myeloid cell suppressive function, and the second one is enhancing cytotoxic T cell and NK cell killing. And so we don't have any real data on the myeloid cell suppressive function and targeting that yet for this malignancy. And that's certainly something that we'll want to work on in the future. But we do have some insights in terms of translating this approach in enhancing cytotoxic T cell and NK cell killing that I just want to briefly touch on. So a couple points. One way that we can enhance T cell and NK cell activity, many of us are familiar with immune checkpoint blockade, where when a tumor dies, they release tumor-associated antigens, and these can be processed by antigen-presenting cells, and which can then go to lymph nodes, and antigen-specific T lymphocytes can be activated and then expand. And these can go back and then eradicate antigen-presenting target tumor cells. And these are T cells in particular. And tumors can supplant this by, in some cases, by using immune checkpoints. And by targeting this, we can release these inhibitors and allow for T cells to recognize the tumor and to eradicate tumor cells again. And so we can do this with immune checkpoint blockade, and this is one way that we can release the brake, so to speak, in terms of T cell recognition and destruction of malignancies. And some of these antibodies can also be recognized by NK cells when they have the FC region retained on these immune checkpoint inhibitors. And NK cells through ADCC, which stands for antibody-dependent cellular cytotoxicity, can also recognize these antibodies in some cases, and also destroy tumor cells. So one way that we can further activate NK cells and T cells is through cytokine receptor superagonism. And one method of doing this is through an interleukin-15 superagonist. And this can activate NK and T cells and also lead to additional proliferation of these cells. An additional way that we can try to translate and target what was shown from Diana's work, as you recall, there are very few NK cells in chordoma, and they were very poorly activated in terms of what she found with the granzyme activity. And so another approach is using an adoptive NK cell therapy, where we can actually administer many NK cells to the patient. And one example is this is an engineered natural killer cell called a PD-L1 Hank. And what this is this is a natural killer cell, and it retains cytolytic granules such as perforin and granzyme. It also has been engineered to have a chimeric antigen receptor here in green, and this chimeric antigen receptor is to PD-L1, and so it can recognize PD-L1 on cancer cells. This is also engineered in that it's a high affinity NK cell, and that it has the high affinity CD16 receptor, which, as I mentioned, helps to recognize antibodies such as those that are used for immune checkpoint blockade, and can further enact NK cell function. I wanted to just briefly touch on, we had another MRSP student who did some of this work in terms of looking at activating NK cells, and his name was Austin, and he was another medical student. And so what he did is he took peripheral blood mononuclear cells and actually sorted natural killer cells from these PBMCs, and then took these natural killer cells from normal healthy donors and either treated them with this interleukin-15 superagonist or left some untreated. and then took the chordoma cells and exposed them to indium-111, and then combined these together. And based on the degree of indium-111 release that was measured, we could detect the degree of tumor cell killing by these natural killer cells. And just to briefly summarize what was found using this translational approach is the anti-PD-L1 antibody was combined with the interleukin-15 superagonist, and we want to know whether we could combine these together and whether this could enhance natural killer cell killing of chordoma cells. On the top row are 3 clival chordoma cell lines, and on the bottom are 3 sacral chordoma cell lines. And just to walk through these graphs, in green, over here on the left, this is our baseline level. When we add normal human donor natural killer cells, we see just a very little amount of of chordoma cell killing. In blue is when we add the PD-L1 inhibitor. We can see that there's between a 20 to 40% natural killer cell killing of these chordoma cells. When these NK cells are pretreated with the interleukin-15 superagonist, that's here in gray, we can see also enhancement in NK cell killing of chordoma cells. And in purple is when we combine these together. We can see that this combinatorial approach is able to activate human donor NK cells to destroy these chordoma cells. The other approach that I mentioned is the adoptive NK cell therapy approach, and using these PD-L1 T-hanks. He also found that using these 2 cell lines in chordoma that an adoptive NK cell therapy approach was also effective at killing these chordoma cells. So we're hoping that once we refine our combinatorial approach through combining some of these ways of enhancing T cell or NK cell function, and that we can target this or combine this with targeting of the myeloid cell suppressive function, that we will utilize Diana's study of the chordoma tumor immune microenvironment to design a rational combinatorial immunotherapeutic approach, which we aim to advance in the clinical trial setting. And so we hope to do this at the NIH. And as I mentioned, this is a 200-bed inpatient research hospital. And one of the advantages of trying to do rare tumor clinical trials at the NIH is that we're able to provide travel and lodging for patients to come from all over the country in order to participate in these clinical trials, which makes it feasible to do clinical trials on rare tumors such as esthesioneuroblastoma that we mentioned, or chordoma, or others that are rare tumors. So just to flip gears really quick, Diana had also mentioned our interest in esthesioneuroblastoma, also known as olfactory neuroblastoma. And we do have a clinical trial that's up recently for this that I'm going to discuss. But just a little bit of background, as she mentioned, there has been some preliminary characterization of the immune microenvironment. And just to briefly summarize one of our recent studies, we found that about 40% of esthesioneuroblastoma do express PD-L1, and that esthesioneuroblastoma that express PD-L1 also do have significant infiltration of immune cells. And taken together, our preliminary study indicated to us that olfactory neuroblastoma may be susceptible to immune checkpoint blockade. And as I mentioned, we recently opened a clinical trial for recurrent or metastatic olfactory neuroblastoma. This actually opened about a month ago, and we've enrolled 1 patient so far who's been started on this, and have been working on enrolling additional patients for this study. And just to describe how we're doing this clinical trial, this is using a combinatorial antibody, and this is a combination of effectively avelumab, which is a PD-L1 inhibitor, and this is fused with a linker to a TGF-beta receptor 2 extracellular domain, which acts as a TGF-beta trap. So in the combinatorial or simultaneous setting, we're blocking both PD-L1 as well as TGF-beta in the tumor immune microenvironment. So the reason that we've also included TGF-beta for olfactory neuroblastoma is TGF-beta is a pleiotropic cytokine. It's known to suppress host anti-tumor immune response through multiple ways. It does this through inducing FOXP3 regulatory T cells away from a Th1 phenotype. It also does this by attenuating CD8 effector activity and cytotoxicity. It also suppresses NK cell activity as well as interferon gamma expression. Furthermore, it induces tumor cell plasticity through induction of an epithelial to mesenchymal transition, through downregulation of epithelial markers such as E-cadherin, and upregulation of mesenchymal markers such as fibronectin and vimentin, and through increasing cell invasion migratory potential in metastasis of tumor cells. When we looked at the expression of TGF-beta, the different isoforms in olfactory neuroblastoma, that's here in blue, and this is TGF-beta 1, 2, and 3, we found a similar degree of TGF-beta expression in blue compared to head and neck cancer here in the salmon color. And CD274, this is PD-L1 or another name for it. So we found a similar degree of PD-L1 as well as TGF-beta expression in esthesioneuroblastoma. And this suggested to us that these tumors may be susceptible to combinatorial inhibition of PD-L1 and TGF-beta. So just some additional background about the concept in terms of inhibiting PD-L1 and TGF-beta at the same time. Agents that target TGF-beta alone, including small molecules or neutralizing antibodies, have seen limited clinical success in clinical applications. And this particular agent binds all three TGF-beta isoforms. And this can tailor, as I mentioned, TGF-beta sequestration of the tumor microenvironment and counteract immune tolerance through both immune checkpoint blockade as well as inhibition of TGF-beta pathway. And furthermore, this fusion has been found in some xenograft models in other tumor types to be more effective than combining anti-PD-L1 or TGF-beta receptor 2 agents independently. This agent has been used in a couple phase 1 clinical trials at the NIH and been found to have a good safety profile. So our trial for esthesioneuroblastoma, our objective, this is specifically for those patients who have recurrent or metastatic olfactory neuroblastoma that is not amenable to potentially curative local therapies. These patients have typically undergone surgery, radiation, chemotherapy, and had a recurrence or metastasis, and have not been. This has not been well managed by other approaches that have not been effective. And our objective is to understand and assess the objective response rate in patients with recurrent or metastatic esthesioneuroblastoma. This is a single institution, single arm phase 2 trial where patients are treated with an infusion of this agent every 2 weeks for a year. Initially, we're enrolling 12 patients, and if we see activity, we will open a second stage, which will enroll another 9 patients for a total of 21 patients. And we do have early stopping rules for safety to be applied if necessary. Some of our secondary objectives are to assess the safety of combinatorial PD-L1 and TGF-beta inhibition in olfactory neuroblastoma patients, as well as to assess the duration of the response and progression-free survival. We're also doing many exploratory objectives where we're looking at immune correlative studies in the peripheral blood, as well as in the tumor. We're looking at immune cell subset quantitative and functional analyses, PD-L1 expression, and evaluation of soluble factors and intratumoral changes before and after treatment. And when we can, what we're trying to do is using what Diana has set up for these different tumor types from the multispectral analysis. We're hoping to get biopsies from these patients before and after treatment, and that we can use these pre and post treatment samples in the multispectral immunofluorescence setup to understand what changes happen to these different immune cell compartments before and after treatment with this agent. I just wanted to briefly touch on for the head and neck group that we did recently publish in the last several weeks using this PD-L1 and TGF-beta blockade in HPV unrelated head and neck cancer in a clinical trial at the NIH for 14 patients. This was done in a neoadjuvant setting and found some interesting results. If those in the head and neck group are interested, just want to briefly mention that. So in conclusion today, we can conclude that sinonasal and skull-based malignancies may be susceptible to combinatorial immunotherapeutic approaches. I've shown some in vitro evidence that would suggest that these tumor types may be susceptible to these approaches, and that the other conclusion is that with characterization of the tumor immune microenvironment, it's essential to do basic studies such as these because these can help us to develop rational strategies for combinatorial immunotherapy approaches for sinonasal and skull-based tumors. So I just want to acknowledge the members of my lab that did much of this work that I presented today, as well as on the left is our clinical trial team that help us with these clinical trials. The esthesioneuroblastoma trial that I mentioned, I run this with Dr. Flutis, who is a medical oncologist at the NIH, and we run that esthesioneuroblastoma trial together. For the trainees in the group, I just want to briefly mention the otolaryngology surgeon scientist program, which is the program that I'm part of at the NIH. This is a junior faculty mentored research program where otolaryngologists who have completed their fellowship are able to have a tertiary care clinical appointment. Mine is at Johns Hopkins, but it can be at any hospital in the National Capital Region, and then an intramural research lab at the NIH. So for those who are trainees who may be interested in a surgeon scientist program, I just wanted to put a plug in for that, so that those people are aware. Lastly, I just want to acknowledge my other collaborators at Johns Hopkins, as well as our funding sources. And here my contact information, as well as the email address for the medical oncologist who runs these trials with me. And then again, I just want to thank everyone for your interest and participation, and for the invitation for us to speak today.
Thank you, Nyall and Diana. That was amazing. Diana, great job. I mean, I can relate to how it can be challenging to do basic science research, but you did an amazing job, it looks like. So congratulations. And I'd like to open it up to the crowd for questions or comments.
I had one question. This is Varun Kashetri. I just first wanted to say congratulations to both of you, and especially Diana, who's spent a couple of years with Dr. Racinos and myself doing skull-based research from above, so to speak. But I wanted to ask Diana, or maybe in any other studies, to what degree do we know if what's happening with the immune system in the tumor correlates with what's going on with the peripheral blood? And the reason I ask that is, for example, as a corollary in skull-based meningioma, there's a recent study kind of looking at when you combine genetics, epigenetics, proteomics, and you kind of look at overall what kind of cell processes are upregulated. The Toronto group kind of divided it into 4 types, and like one type was more immune driven, whereas another type might be more cell proliferation driven versus hypermetabolic versus angiogenic. And the kind of rationale behind that was that while immune therapy trials, why those maybe didn't work in meningioma, is because we're not just targeting the immune driven tumors, we're giving it to everyone. And so I'm wondering if there's a corollary in the peripheral blood, we might be able to kind of pick out better, like which tumors might be more likely to respond to immunotherapy.
Thanks for your question, Dr. Kashetri. Yeah, about the peripheral blood, this particular study, we didn't really correlate that information. I think that's probably a future direction for us to look at to see if there is a relationship between that tumor microenvironment and chordoma and what's found in the peripheral blood. We do know when we do some of the adoptive like NK transfer work, like Dr. London was alluding to, when we either like supplement NK cells and for the patient, we do have a chordoma tumor cell lysis. So that is like one corollary I can think of. But while I was writing up this paper, I actually did read about some of the rationale people had come up with for why some tumors respond to immune checkpoint blockade and why some don't. And one of the things that kept coming up was actually tumors that have high TAMs, tumor-associated macrophages, which are thought to be immunosuppressive in their microenvironment. That may be one of the reasons why why those patients are not responding to the immune checkpoint blockade, because if you are giving this therapy, which could be efficacious towards those T cells, but the T cells are being inhibited or abrogated by another cell type, we won't see the effects of that therapy. So that could be one approach to that. In terms of diminishing the abrogation of the myeloid cells to allow other effector cells to take over, which come from the peripheral blood. In terms of like the epigenetics you had talked about, and the different categories for how tumors respond or don't respond. As I mentioned before, there is a study that was looking at done by Dr. Allen actually in head and neck squamous cell carcinoma, looking at the CSF2 gene, which actually encodes granulocyte macrophage colony stimulating factor. It's linked to myeloid-derived suppressor cells. And in patients who had high expression of that gene, they did not respond well to PD-1 inhibition, to the immune checkpoint blockade. So it's probably multifaceted why people respond and some people don't, genetic, epigenetic. We're trying to get at the answer in the tumor immune microenvironment to see if there's something we can alter there first to increase the efficacy of these therapies. And looking at peripheral blood correlations is probably a really good future direction to look at as well.
Yeah, thanks, Varun, for your question. I think just the one thing that I would add is hopefully when we get this in the clinical trial scenario, where we're also collecting peripheral blood, we can try to add on some additional immune cell correlates. But that's a very good question.
Thanks, guys. Great work.
Dr. Silver had her hand up.
Hey, this is Natalie Silver. Congratulations, Diana. Awesome work. And Dr. London, congratulations on your clinical trial. It's a really amazing feat to get these, translated into clinic. So, kudos to you for getting that accomplished. I had just two questions more about your modeling. Do you guys in Chordoma have any good murine models? And the other question I had is, have you considered looking at spatial transcriptomics as an adjunct to your multispectral fluorescence? That data is beautiful, but there's there's additional power that you can harness with your valuable samples in terms of the gene expression profiling and things like that. I was just wondering if you've thought about that at all.
That's a good question. Thank you. So to answer the first part of your question, yes, there are mouse models for chordoma. Since it's a very slow growing tumor, they're very slow growing, and the humanized models are also very challenging, but they are feasible. For esthesioneuroblastoma, there aren't any yet, but our lab is working on generating those, and hopefully we'll have some of those soon that we can use. In terms of spatial transcriptomics, that's a very good point and a very good question. We have not done that specifically for spatial transcriptomics. We are pursuing single cell analysis for some of these tumor types, and hopefully once we're able to recruit more patients to the NIH for these trials, we can collect more of that fresh tissue for patients who have recurrent or metastatic tumors that we can use for those studies. So that was the way that we were hoping to look at it, but spatial transcriptomics is also a very good way that we could potentially overlap that over the multispectral work that has been set up by Diana.
Dr. Racino?
First of all, Diana continues the intellectual exchange between the Cleveland Clinic and Johns Hopkins with Dr. Byrne, Dr. Koo, Dr. Genther, myself, and I'm sure there's some others that I'm missing. So really proud of the work that you're doing. Diana, again, did work with us. She's well on her way to becoming a true hybrid skull-based surgeon by looking at both sides. And now that she's not in the running for neurosurgery, I would just tell all of you that if you don't highly recruit her, you're making a big mistake. So one question, these tumors, especially at the skull base, are incredibly challenging, and there can be limits to resectability even with the most advanced open endoscopic and reconstructive techniques that exist now. Is there any other tumors or possibility that you would see in the future of us targeting the tumor microenvironment in the ways that you're talking about to do neoadjuvant therapy to potentially shrink a tumor down that would change potentially our ability to at least resect all the gross disease. Of course, a question comes up like, what do you treat with radiation, for example, afterwards? Do you treat the original tumor bed, or do you treat the just what the remaining tumor bed was? But is there any history of that already with targeting tumor microenvironment, or that you could see down the future? And Diana, if you want to defer that to Dr. London, that's okay too. I know it's a more big picture question.
Yeah, I would just add, so I have tried, in terms of trying like a neoadjuvant approach for skull-based tumors, I have tried that for several patients on top of or in the midst of other, head and neck neoadjuvant trials. So for like sinonasal squamous cell, for example, to me, I find it challenging because, as you mentioned, the tumors, typically they're closely related to critical neurovascular structures, and neoadjuvant immunotherapy doesn't typically work very quickly or very rapidly. And so I do worry about, growth and perhaps changes in resectability while we're working on doing it. So I think, it's a very short time interval, and it can be, I think neoadjuvant immunotherapy can be very challenging. These are rare tumors, so it's going to be hard to ever get enough data, I think, from a neoadjuvant approach. And I think there are a lot of challenges to doing that.
I just wondered with chordoma as an example, given that it's probably a lot slower growing than in general than, for example, a squame. And with the work that you guys demonstrated, that there's less variability, for example, with the sacrum or with, the clival region, whether that would be an opportunity that could be explored in both of those regions, frankly, because the sacral chordomas can be very, very challenging to resect as well.
Yeah, that's a good point. Certainly, chordoma, you definitely could do a neoadjuvant immunotherapy approach just with how slow growing. We could get several cycles in, before we had to go, for surgery, just with how slow growing they are. I think that would be a good way to approach it. It would be nice to be able to use these approaches before the tumors have already undergone like rounds of radiation and other forms of treatment that can cause them to maybe be less susceptible to some of these immunotherapeutic approaches. By doing this as a neoadjuvant setting, we could allow the patient's immune system to generate an immune response to all that tumor antigen that's still there before we remove all of it. So I think that there are, certainly for chordoma, I think that it is definitely feasible to do that, and hopefully we could try to reduce the amount of the high recurrence rate for chordoma by using a neoadjuvant approach for that.
Thank you.
I have a question. Actually, two questions. They're related. How does the immune cell spatial profiling in these tumor immune microenvironment of chordomas compared to other known immunogenic cancers like melanoma or squamous cell cancer? And then have you tried, you discussed you did PD-L1 staining for esthesia. Have you tried it in chordoma? Because I feel like that's like the one correlate we do get, before initiating any immunotherapy.
Go for it, Diana.
Okay. Yeah, I'd say that we talked a lot about like a hot versus a cold tumor. So like a breast cancer is an example of a hot tumor, one that's highly infiltrated by T cells, has a lot of immunogenic activity and responds well to immunotherapy. And then a prostate cancer would be an example of a cold tumor, not as immunogenic, does not respond well to immune checkpoint blockade. So I would say that chordoma probably is closer to that cold side of the spectrum, but that may be, again, because we're finding so many immunosuppressive cells in that region, and that may be something that we can actually alter with our therapies. Additionally, I read a study about esophageal cancer, and they showed that with high tumor associated macrophages, there's a poor response to induction chemotherapy in esophageal cancer. So we're seeing these trends hold through across multiple cancer types, which makes it a more generalizable idea in applying these studies. And then to the second point, Dr. Koo, your question regarding PD-L1, we actually have stained for that. It's our fourth panel, which wasn't presented here, but it's something that I'll be working on during my research elective in January. I'll be analyzing that new panel. It's the cancer stem cell panel. We're looking to see whether cancer stem cells within the chordoma tumor immune microenvironment, what they look like, whether we can characterize them, and whether that has any correlation to the high recurrence rate that chordoma has. And so part of that cancer stem cell panel includes the PD-L1 target. So we did stain for that, just haven't analyzed it yet. And that cancer stem cell panel has been used in anesthesio as well. So we'll have those results hopefully in the next few months.
Any other questions? It's at 8:05. All right, so I'd like to again thank Dr. London, Diana, amazing job. We look forward to seeing you for your last week of your sub-I. All right, everyone have a great day. Thank you so much, guys.
All right, thank you.
Thank you so much.
Thank you.